A very good day, my dear postgraduate students. The topic for the day is a little strange. Chrome endoscopy. Some call it as chromoendoscopy. And this is a university question in one of the universities. I picked it up because I myself was a little inquisitive about it. On the screen, I am finding a Lugol iodine as well as a white light endoscope seeing the mucosa. My talk is on these references and it deals with the indications, stains, as well as the techniques in chrome or chromoendoscopy. These are the panel of authors over here. And on the screen again, I'm seeing an Alamy picture, a source that has given wonderful contribution to different pictures in all walks of life. And I would advise you people to kindly go to them if time permits. The definition: chromoendoscopy is a diagnostic method in which a chemical substance is being sprayed onto the mucosa, particularly the gastrointestinal tract, to highlight the specific areas and to distinguish it from the surrounding different types of epithelium. So that will be the definition. So you can remember gastrointestinal tract, epithelium, lesion, surrounding tissue. That is what is happening over here, courtesy John Hopkins. Now, what are the indications and advantages? So there is an early detection of malignancies because the endoscopic picture by itself is a little bland, and many a time we have seen a non-representative biopsy, which can be reduced in the case of chromoendoscopy. It is for the visualization and the detection as well as the biopsies of neoplastic lesions. It can be used in combination with another thing called the magnifying endoscope. Always you find that the endoscope can be attached to a camera, which in turn can be attached to a computer. There can be a provision for magnification. So the advantage at the other end, the pathologist must be aware of. Ranges from a simple Barrett's esophagus of metaplasia to dysplasia to malignancy can be undone by means of the potential of a chrome endoscope. White or the routine endoscopy might miss these lesions, particularly when they are small. So this again is a picture. There is a mucosal fold which can be brought out. There are some areas of congestion and so on. And whether the endoscope or the endoscopist with his own camera and computer can detect all this is a little doubtful. What are the stains that are used for coloring the mucosa? They are broadly divided into the absorptive stains, contrast stains, and reactive stains. And this particular panel, you people can remember: Lugol iodine, methylene blue, toluidine blue, crystal violet. And this is the chemical name for it. If possible, you can. Indigo carmine is another one. Reactive stains can be Congo red and phenol red. These are the things. The absorptive stains are mainly used to identify the epithelial cell lesions by means of selective absorption. Contrast stains, on the contrary, they seep through the mucosa and the crevices, and they highlight the topography of mucosal irregularities. Reactive stains can undergo chemical reaction or they act based on the pH, as a result of which we get an outstanding picture. So this particular classification of stains, I think it will fetch us dividend. What is needed for this chromo or chrome endoscopy? One is obviously an endoscope. Then when I say chrome, which means color, a dye is needed. Then what are the spray catheters? The different types of dyes we had seen in the previous slide itself. A spray catheter is one that sprays the dye onto the mucosa from where it gets absorbed or layered. These are the different types of spray catheters. Glow tip is one, Mystifier and PW6P1. These are all different trade names that are given so that we do not know the details of it. That is what happens in immunohistochemistry markers also. So pictures from GATE, the research gate. So this is one picture of normal, and then this is being coated with iodine. See the difference in the picture. And pan endoscopy, again, you find that the iodine, it coats a different picture, a color, etc. versus the normal. There are some map-like areas which are being found here and which could be missed over here, though there are some pale areas as such. GUT is a journal of reference, conventional and chromoendoscopy. So in this one, I am finding that there is a polyp and arrow marked also, you are able to find it. This is a Barrett's methylene blue. And in a Barrett's esophagus, when the methylene blue is being sprayed, it coats the lesion with a different color. Methylene blue by itself is a metachromatic stain. Pancolonic chrome endoscopy using indigo chrome versus norm. This is what we had seen in the earlier picture. Electronic chrome endoscopy is another one, a further development on it. And what are the clinical applications? Earlier, I had shown you the states. Esophagus, you can go in a sequential manner. Esophagus, Barrett's esophagus, early gastric cancer, or esophageal carcinoma. Stomach, metaplasia, Helicobacter pylori, early gastric cancer, and polyp. Duodenum, there can be the malabsorption syndromes, ampullary carcinoma, quite important. Familial polyposis, okay, I shall come to that at a later slide. Small intestine, angiodysplasia, quite rare. Biliary tract, cholangiocarcinoma, again difficult to visualize, even if an ERCP is going to be used. Colorectum, characterization of polyps, IBD, dysplasia, etc. So kindly by heart this particular list. This will be the applications. Familial adenomatous polyposis and MAP, MITHU, associated polyposis, colonic and extracolonic cancer. And this is supposed to be the MITHU, which means the base pair repair. And when this is going to be defective, the manifestations are made out in the mucosa, which can be identified by means of the chromoendoscopy. The applications, as I told you, MAP and familial adenomatous. The picture that we are seeing is too obvious, but sometimes there can be the development of polyps and in the early lesion that can be identified. This will be important because there can be dysplasia and there can be a progressive malignancy out of it. There is a side viewing endoscope. Probably I do not know the technicality of it. The lesion can be visualized from the side and then completely studied. It is essential to ensure the ampulla is being adequately visualized, as in the case of an ampulla of Vater, etc. What is the stain? What is stain and the uses? There are two groups of it. One is called the vital stain, which is the methylene blue, small in the large intestine, diagnosing ulcerative colitis, metaplasia, and colonic polyps. Lugol's iodine for squamous cell carcinoma of the esophagus, mainly the glycogen containing. That is the principle of amyloidosis. Cressyl violet or crystal violet, small and large intestinal crypts can be seen. For the polyps, for the Barrett's esophagus again, and for the early gastric cancer. These are the other two sites. Contrast, that is, when you do a contrast dye, you find that that particular lesion takes up a color, whereas the background takes up a different color. Sometimes it can be used for a negative staining, chronic ulcerative colitis, intestinal metaplasia, and carcinoma, and acetic acid in a case of Barrett's esophagus. So these list of stains and the applications you people can remember. The advantages will be recognizing minute changes. So when it is too obvious, then it is overdone. Advanced imaging. So this can be fed onto the computer and the image developed. Brilliant resolutions of suspicious lesions. Pre-malignant conditions. Sometimes in surveillance programs, as in the case of polyposis or in case studies. Targeted small biopsies, wherein you are able to identify a lesion initially and that particular lesion is being treated. That is called as targeted biopsy and treatment. On the whole, it would reduce the histopathology workload and cost. When the diagnosis is going to be correct, when the sampling is going to be correct, and then there is an early disposal of material. A beautiful procedure, and then this is studied onto the screen. Thank you for your attention.